Hello, everyone. Very nice to see you again in our GN Fellowship webinar. And today we have a very big task to cover, a very huge assignment to do, which is we are going to update you with the primary and secondary glomerular diseases that was published this year, I think in March. So a very important topic. And we used to teach this topic for the whole year in our fellowship. But today we are going to give you a crash course with the up-to-date management of both primary and secondary GM. Here are today's agenda. The first speaker will be Professor Mujtaba Quadri, and will update us on the recent guidelines for treating both membranous nephropathy and IgA nephropathy. Then Professor Nicci Wearne is going to teach us about the up-to-date management of diabetic kidney disease. Then Professor Rasha Samir is going to educate us with the lupus nephritis new guidelines and the management. Then Professor Urmila Unandh is going to give a great presentation on ANCA-associated vasculitis. We have two moderators, Professor Piere Ronco, one of the most eminent and well-known professor in the GN field. He is practicing in Paris, France. And Professor Georgina Piccoli, she's originally from Italy, but also she works with Professor Piere Ronco in France. So here is our program board. We have board from all over the world, very well known, from our academic director, Professor Muhammad Sabh, our honorary board advisor, Professor Piere Ronco. We have Professor Bianca Davidson and Professor Nicci Wearne from South Africa, Professor Rasha Samir from Egypt, Professor Manish Rathi from India, Professor Mujtaba Quadri from Pakistan, and Professor Urmila Unandh from India. Last year, we graduated close to 130 fellows who finished their one-year online GN fellowship program. This year, we started in January, and we are going to start Module 2 of the 2025 GN Fellowship next Monday, June 2nd. So what we choose to do is we try to avoid monologues or unidirectional education. We try to involve you. We try to help you to get engaged in patients' management. This fellowship is structured as 3 modules, 16 weeks each, and all the educational materials are delivered through a smart platform with weekly assessment and evaluation, critical thinking and appraisal. And as you see, we are gathering a panel of expertise. All of our fellows' activities and assignments are monitored in our smart platform, and there will be weekly quantitative and qualitative evaluation, not only based on the scores they get, but also based on the engagement and their performance throughout the whole year in the program. Here is a timetable for Module 1. We started with the basic introduction about approach to glomerular disease, nephrotic presentation versus nephritic presentation. Then we have GN histopathology introduction. Then we focused on all kinds of podocytopathies. Then we moved to common glomerulopathies with membranous nephropathies, diabetic kidney disease, IgA nephropathy. Module 2, that's going to start on Monday. We are going to start with advanced GN histopathology, then lupus nephritis, ANCA-associated vasculitis, infectious-related GN and pregnancy, onconephrology, amyloidosis, February GN, immune tactoid GN, MBGN, C3 glomerulopathy, and cryoglobulinemia. And the last module will be focusing on rare type of glomerulopathies and the challenging cases with hereditary nephritis, post-transplant GN, TME, lesson from treating GN patients, newer immunosuppressive protocols, role of plasma exchange, and novel and pipeline therapeutics. Again, if you are interested and if you haven't joined yet, you can join module 2. So there is a promo code you can use, early 10, to get 10% discount. And again, we are back to our webinar today, and we are going to start our first presentation. But before that, I just remind you and myself that all of these activities we are doing is to improve our patients' outcome, because the great aim of education is not the knowledge, but the action. With that, I'm going to start the first presentation, which is a presentation done by Dr. Mujtaba Quadri, and he is going to teach us about the new guidelines in treating IgA nephropathy and membranous nephropathy.
Wherever you are, welcome to our update in primary and secondary glomerular disease webinar. And my job is to talk about what's new in membranous nephropathy and IgA nephropathy, and hope to take you through some of the critical facts and newer evidence that we are now looking at in these diseases. So with this background of membranous nephropathy, let's look at what we have learned lately from genome-wide association studies. So there's a susceptibility loci identified now within PLA2R and HLA DQA1 genes in Caucasian cohorts, and individuals who are homozygous at both loci actually carry 80-fold increased risk of developing membranous nephropathy. In terms of environmental and lifestyle factors, a large multicentric study from China has demonstrated the association of fine particulate matter, so that every increase in fine particulate matter 2.5 by around 10 milligrams per cubic meter increased the risk of development of membranous by 14%. The NEL1 antibody-mediated membranous nephropathy has now also been known to be associated with the use of medications containing lipoic acid and complementary and alternative, mainly herbal medicines and mercury-containing skin lightening creams, as demonstrated from recent reports by Narayan and colleagues. In terms of classification, membranous is now classified as either PLA2R positive or negative, and the prevalence of PLA2R is now known to be between 53 to 82%. Thrombospondin 7A, discovered in 2014, accounts for 15% of all membranous and usually has the either a primary association or malignancy-associated membranous nephropathy association. NEL1 is now becoming the second most common antigen after PLA2R, but others like semaphorin 3B in pediatric membranous nephropathy have been reported. HTRA1 has been demonstrated in elderly membranous nephropathy. PCSK6 association has now been reported with NSAID-induced membranous nephropathy, and emerging evidence suggests that we really have complement activation in membranous primarily by the classical pathway. So this table kind of summarizes some of the common antigens and the associations with PLA2R, mostly common between 35 to 60 years, and thrombospondin at a later age of onset 50 to 60. But then the others are in different areas, but semaphorin 3B is primarily at a younger age. When we look at the incidence, PLA2R is obviously 70 to 80%, but now NEL1 is 6% to 21% of PLA2R negative membranous nephropathy now. When you look at the circulating antibodies associated with this, predominantly IgG4 is what's reported with PLA2R and thrombospondin 7SA, as well as with HTRA1 and contactin-1. But when we're looking at commercial availability, it's only there for PLA2R in the form of ELISA or indirect immunofluorescence, and also with thrombospondin 7SA. When we have suspected membranous nephropathy, one can order PLAR immunofluorescence testing, and if it is positive, one can do an ELISA, and if the ELISA shows greater than 2 RU per ml titer, one can diagnose membranous nephropathy and avoid a renal biopsy. But if the ELISA is negative or less than 2, then one would obviously need to perform a renal biopsy when there's an indication, and take it from there in terms of staining for PLA2R antigen and thrombospondin 7SA. The treatment strategy is around a two-pillar strategy with non-immunosuppressive supportive care, which is the initial and ongoing management that is there for all patients. Immunosuppression is reserved for those with disease progression or with life-threatening complications. Risk stratification is extremely important, and these may be based on the clinical profile, whether you have proteinuria greater than 8 grams per day, or kidney dysfunction, which is obviously higher risk, and subnephrotic proteinuria, usually with preserved renal function, has a benign course. One study showed an annual decline in kidney function of around 0.93 ml per minute per year in those who maintained subnephrotic proteinuria versus minus 3.5 ml per minute per year in those progressing to nephrotic range. The serum and urinary biomarkers, high anti-PLA2R titers, are associated with the lower spontaneous remission rates. And in one study, there was only 4% remission in the highest tertile, greater than 610 RU per ml, compared to 38% in the lowest, which was less than 175 RU per ml. And KDIGO suggests that greater than 50 RU per ml should be taken as high-risk categories. Histologically, chronic changes like glomerulosclerosis, tubular atrophy, and interstitial fibrosis indicate a higher risk of poor outcomes. KDIGO guidelines, we are aware, classify the risk into low, medium, high, and very high, and we'll look at that subsequently in one of our slides. For supportive care, we understand it's dietary, all about dietary salt restriction, smoking cessation, weight management, RAS or ARBs, blockade as primary antiproteinuric agents. SGLT2 inhibitors with DAPA-CKD have not provided any definite evidence of benefits, although there's some proteinuria reduction in membranous. Diuretics are needed for your edema, and lipid-lowering agents and anticoagulations when the albumin is less than 2 to 2.5 primarily. KDIGO recommends low molecular weight heparin or warfarin because of the NOACs not having very certain pharmacokinetics in nephrotic syndrome. In L1 related membranous nephropathy, if particularly linked to complementary alternate medicine and skin lightening creams, just discontinuation should relieve the condition in about 50% of the cases. What about persistent nephrotic syndrome, declining kidney function, or high-risk features? Alkylating agents and corticosteroids from the time of Ponticelli, cyclophosphamide, chlorambucil, and prednisone were effective in inducing complete remission in 24 of 42 and partial remission 10 of 42 in one RCT, and safety concerns are now pushing these out of favor. However, they still have room, as we will see. Calcineurin inhibitors like cyclosporin and tacrolimus have shown multiple trials with superior remission rates compared to supportive care or steroids alone at 12 and 24 months. However, relapse upon withdrawal is common, and long-term nephrotoxicity is a risk. One study compared tacrolimus and corticosteroids to cyclophosphamide and corticosteroid and found comparable remission rates at 12 months, but poorer sustained remission with tacrolimus at 2 and 6-year follow-ups. Rituximab as an anti-B cell therapy, observation studies have shown efficacy in treatment-naive, relapsing, and resistant membranous. When in GEMRITUX trial, no difference in primary outcomes at 6 months comparing rituximab versus supportive care, but a higher clinical remission rate at extended follow-up, 66% versus 34%. In the MENTOR trial, when rituximab was compared with cyclosporin for 12 months, at 12 months, rituximab was non-inferior to cyclosporin and superior at 24 months at maintaining remission of proteinuria. However, there were more side effects in the cyclosporin group. In the RICYCLO study, which compares rituximab to cyclophosphamide and steroids, and concluded that rituximab was comparable to cyclical therapy at 12 months, with sustained effects observed until month 36. Up to 40% of patients on rituximab do not achieve remission after 2 years, and efficacy may be particularly low in those with very high anti-PLA2R titers, particularly above 172. So the KDIGO stratification we're all familiar with: low risk, moderate risk, high risk, and very high risk, all the way from less than 3.5 grams per gram proteinuria initially to more than 3.5 grams per gram to more than 8 grams per gram, or to life-threatening nephrotic syndromes, and with the associated hypoalbuminemia and risk of thromboembolic phenomena. One can just wait and see for the low risk category, and either wait and see and hope for some response or spontaneous remission, or start rituximab or CNI plus steroids. And when you go to the higher risk, if your renal function is normal, use rituximab or cyclophosphamide plus corticosteroids if renal function is abnormal, or CNIs plus rituximab is one other possibility. And with very high risk, cyclophosphamide plus glucocorticoids are recommended. In terms of emerging therapies, obinutuzumab is a more potent anti-CD20 antibody, and even in rituximab-resistant cases, one report reported 85% complete remission or partial remission in 59 patients. In another study, 20 of 21 patients treated with obinutuzumab achieved remission, compared with 28 of 42 treated with rituximab, with the former acquiring more complete remission, 38% versus 14%. Sequential therapy: one study looked at cyclosporin for 6 months along with 2 doses of rituximab, day 0 and 6 months, and reported a remission rate of 92% at 6 months, with a complete remission rate of 54%, and the remission rates were higher than those historically treated with rituximab alone. The sequential treatment with tacrolimus and rituximab versus alternating steroids and cyclophosphamide, the Starman trial, was an open-label study which had 86 patients with primary membranous, with evaluated sequential therapy of 6 months of treatment with tacrolimus, followed by a single dose of rituximab, and compared this with corticosteroids and cyclophosphamide, and the cyclical therapy was superior to the sequential treatment. In hybrid therapies, combinations of rituximab, cyclophosphamide, and steroids, the immunological and clinical remission rates of 100% and 93% respectively reported in 60 patients with treatment-naive, relapsing, and resistant membranous nephropathy. A recently controlled trial looked at combination of cyclosporin, MMF, and prednisolone to cyclical steroids and cyclophosphamide, and comparable remission rates. The anti-PLA2R targeted therapy using cyclophosphamide and steroids with treatment withdrawal upon negative anti-PLA2R at 8 weeks showed high initial immunological and clinical remission rates, 71 and 76% respectively, potentially limiting drug exposure. When you have membranous nephropathy with kidney dysfunction, there's limited data on optimal management, but one UK study suggested chlorambucil with steroids was more effective than cyclosporin or supportive care in patients with deteriorating kidney function, and retrospective studies suggest a potential role for rituximab in patients with stage 4 or 5 CKD, showing proteinuria reduction and improved GFR in some patients. Resistant nephropathy would be defined with anti-PLA2R testing. Persistence of antibodies at 3 months and end of therapy may indicate resistance or relapse, and 20 to 40% of patients treated with first-line therapies develop resistance. Management often involves switching between first-line agents, cyclophosphamide, steroids, and rituximab, and CNIs have limited utility in resistant cases. KDIGO suggests rituximab resistance, then use rituximab plus CNIs with preserved GFR, or cyclical steroids and cyclophosphamide for declining GFR. If you have cyclophosphamide and steroid resistance, use rituximab. If you have CNI resistance, use rituximab for preserved GFR, or steroid and cyclophosphamide for declining GFR. Other options are hybrid therapies, obinutuzumab and ofatumumab, which have shown promise in resistant cases, including those with anti-rituximab antibodies. Other drugs like ACTH, MMF, bortezomib, dexamethasone, and daratumumab are under a study as well. So in IgA nephropathy, we know of the Oxford-Messi classification, and I encourage everyone to be familiar with that, and most of you would be in their audience. but also but one should be now using the International IgA Nephropathy Risk Prediction tool pretty regularly, which includes CKD, EPI, EGFR, proteinuria over 24 hours, the MAP closest value within 6 months, age for 18 plus only, the race, white, Chinese or Japanese or other, the use of RAS inhibitors prior to biopsy, immunosuppression used prior to biopsy, but the MES score here is used without the C score. And risk prediction is now valid till 5 years after the biopsy, and I think it can be a useful tool to guide our therapy. So again, there's a dual approach to IgA nephropathy treatment, addressing both generic and specific pathways. Treatment aims at both intrarenal responses to nephron loss and IgA nephropathy-specific pathogenic pathways, and whether patients have established CKD diagnosis or not. So the foundational, therapy would include low salt, smoking cessation, weight control, exercise, and then the cornerstone of the foundational therapy is RAS blockade and BP management targeting blood pressure less than 120/70, and titrating the proteinuria to less than 300 milligrams a day. A meta-analysis of 11 RCTs showed that proteinuria reduction was associated with a lower risk of doubling of serum creatinine and kidney failure, death independent of hypertension. SGLT2 inhibitor as a DAPA-CKD subgroup showed protective effects in IgA nephropathy on EGFR and proteinuria, and the hazard ratio was 0.29, although the confidence intervals were a bit wide. However, subsequent meta-analysis of 13 RCTs have clearly shown that RAS inhibitor, the SGLT2 inhibitor use decreases progression of risk by 40% in the glomerular diseases, and specifically in IgA by around 51%. So you have novel endothelin-1 dysregulation, of course, contributes a lot to glomerular hypertension and fibrosis, and targeting these agents, endothelin-1 through sparsentan, which is dual endothelin antagonist, and angiotensin receptor antagonist, or atrasentan, which is selective angiotensin receptor antagonist, both in the PROTECT trial as well as the ALIGN trial, have shown a decrease and decline in GFR compared with irbesartan in the PROTECT trial, minus 2.7 ml per minute compared with minus 3.8 ml per minute, and in atrasentan, again, it seems like there was a significantly greater reduction in urine PCR at 9 months when added to RAS inhibition. The other drivers of therapy include obviously targeting the inflammatory response and fibrosis, and one of the trials, the testing 1 and 2 trials, most of them actually showed decrease in primary outcome, 40% EGFR decline, kidney failure, death, with prednisone 0.8 milligram per kilogram per day, with higher side effects, but also with good effects with 0.4 mg per kg per day of steroids with prophylactic clotrimazole, and still there was some increased infection risk. MMF as an alternative has been used mainly in Chinese patients with where it preserved renal function, allowed for reduced steroid exposure, and hydroxychloroquine also showed some benefit in Chinese patients, but no additional benefit when added to systemic immunosuppression. The intestinal targeted corticosteroid like budesonide in NEFLGARD study showed a 48% greater proteinuria reduction at 1 year versus placebo, and 2-year data also showed significantly lower EGFR loss compared with placebo for an average protection of 5 ml per minute per 1.73 meters squared over a 2-year period. And when you're looking at the APRIL TACI pathway inhibitors like atacicept, significant proteinuria reduction in a phase 2b randomized double-blind placebo-controlled trial. There was a 35% reduction in proteinuria reported for patients receiving 150 or 75 milligrams of atacicept for 36 weeks compared with placebo, and there were some other effects on proteinuria, remission of hematuria as well. Similarly, in APRIL inhibitor, sibeprenlimab, in this phase 2 study, there was mean reductions of 47%, 59%, and 63% in terms of proteinuria with 2 milligrams, 4 milligrams, and 8 milligrams compared with 20% reduction in the placebo group. And there was a slower decline in EGFR as well. when there are other aspects like targeting complement, including iptacopan, in Applause, where we had a phase 2 and interim phase 3 data, which showed significant proteinuria reduction versus placebo, and an interim pre-specified analysis of the first 250 patients showed in the phase 3 trial, Applause IgA, that in addition to optimize supportive care, it significantly reduced proteinuria with supportive care alone, and compared with placebo, and it's now been approved by FDA for IgN. Cemdisiran, RNA inhibitor targeting C5 phase 2 trials also showed a significant reduction of proteinuria compared with placebo, and revolizumab, which is a humanized monoclonal antibody targeting C5 phase 2 trial showed proteinuria reduction and stable GFR versus decline in placebo group. And after 26 weeks, mean proteinuria was reduced by 30% in the revolizumab group compared to placebo. And the mean eGFR remained stable compared with the 24.5 ml per minute GFR in the placebo group. And the phase 3 trial is ongoing. So this kind of summarizes all the 4 hits of IgA nephropathy, from the production of galactose-deficient IgA, to the formation of autoantibodies, to the formation of circulating IgG, galactose-deficient IgA1 immune complexes, through the deposition of immune complexes in the kidneys, and all these areas that we've discussed, whether targeting budesonide or SGLT2 inhibitors, or MMF or BAFF/APRIL inhibitors, or systemic steroids. So I would say you've come a long way, baby. IgA nephropathy, get a 5-star. Membranous, you're getting there, 4 to 5. And the rest of those who've been acknowledged here, all of you are 5-star to me. And thank you for your attention.
Well, thank you very much for these fantastic talks. Very informative. So now we have time for questions. We have 3 minutes. I see questions in the chat. Could you please summarize the questions?
Yeah, so I'll point those which are directly relevant to this presentation first. One is any role for MMF in membranous nephropathy. If you could address that first.
Professor Quadri?
Yeah.
Do you want me to address the question?
Yeah, please.
Okay. So no, there is no place for MMF. I mean, the objective of the treatment is to target B cells and plasma cells. We have very good drugs targeting B cells. Cyclophosphamide is the most effective, but as you mentioned, is toxic when used for a long time at high dose. This is the reason why rituximab is preferred to a cyclophosphamide. And soon we will have the new anti-CD20, and I'm sure this will be mentioned during the talk on lupus nephritis, that is obinutuzumab, which is a super rituximab. This is the way to go. May I remind that the rate of remission is only 60% with rituximab. So we have still some way to go. We need to make some progress, and I'm quite sure that with obinutuzumab we will have a higher rate of remission. And also there are combined therapies using cyclophosphamide, low dose, and rituximab, for instance, or tacro and rituximab. So there is a future for better therapies, but still always target the B cells.
Which is what brings me to the next question. Thank you, Piere, which is like when to expect and test for anti-rituximab drug antibodies. When should one do that?
Well, I'm not sure that anti-rituximab antibodies are frequent, and actually they were discovered by a team in Nice in France, but I'm not convinced that they do have a role in the patients with rituximab therapy. If you have rituximab resistance, I would either reinfuse rituximab or shift to obinutuzumab.
Okay, I think that answers that. Thank you so much. The third question, quick one we can take is, when can we stop anticoagulation in membranous nephropathy? I mean, like, is there some clinical risk, or is just all related to the serum albumin level? When should one stop anticoagulants?
Both. You gave the response. I mean, if there is a high risk of thrombosis because of the past history of the patient, you should be very cautious. I mean, and continue therapy as long as it is needed. In the patients without an history of thrombosis, then serum albumin is the guide. Should be monitored, and anticoagulant therapy could be stopped above, I would say, 20 grams per liter of serum albumin, 2 grams per deciliter. The risk is then very low.
Sounds good. I think so in the interest of time, the other questions, we'll try and come back to them later on, and we'll just go ahead to the next presentation, I would suggest. So we'll come back to the others. Thank you. Thank you.
Thank you.
Thank you so much. Our next presentation will be...
I'm Nicci Wearne. I'm from Cape Town, South Africa. Today I'll be speaking about diabetic kidney disease and not lupus. And I'm going to focus on detection, assessment, and best practice. I'm really proud to be part of the World Kidney Academy. I think it's a fantastic forum to learn about GNs and kidney disease. So approximately 537 million people worldwide live with diabetes. Type 2 diabetes accounts for 95%. 40% of people with type 2 diabetes develop diabetic kidney disease. It is the most common cause of CKD globally. 30% of type 1 diabetics develop diabetic kidney disease, but very sadly, most don't reach end-stage kidney disease, but rather die on the way to kidney disease from cardiovascular disease. That's 90% of people. So the natural history of diabetic kidney disease is actually quite dim. When there's no nephropathy, there's 1.4% mortality, but this increases dramatically by the time one has an elevated creatinine or need for kidney replacement therapy. And this is old data, but an elevated risk of mortality of 19.2%. So there are multiple interrelated pathophysiological mechanisms involved in the pathophysiology of diabetic kidney disease. These involve hemodynamics, which are central to the maintenance of nephron homeostasis and center around RAS, and particularly targeting RAS inhibition, the metabolic effects, a lot about inflammatory effects, and a lot of the new drugs are targeting here, and ultimately fibrotic upregulation. And this all leads and culminates into glomerular hypertrophy, mesangial expansion, tubular interstitial fibrosis, inflammation, glomerular sclerosis, and kidney fibrosis. So diabetic nephropathy refers to both functional and structural changes seen in the kidney. The functional changes start first. These result in, very importantly, hyperfiltration with an increased eGFR, which can indeed increase up to 20 to 50%, and ultimately your GFR will then decline, as well as progression from microalbuminuria to macroalbuminuria. The structural changes also begin quite early, and they begin in the beginning with kidney hypertrophy, and ultimately one develops the Kimmel-Stahl-Wilson nodules that we all know about, as well as interstitial fibrosis, all culminating in end-stage kidney disease. So these slides describe the structural changes in the glomeruli. On the left is a normal glom. On the right, there is an electron microscope of intact podocytes that maintain the integrity of the filtration barrier. Ultimately, when one gets diabetic kidney disease, you can see destruction of the podocytes, leading to loss of integrity of the filtration barrier, leading to proteinuria, specifically albuminuria. The measurement of albumin is extremely important. Not only does it predict kidney disease progression, it also is a direct predictor of cardiovascular disease outcome, with normal albuminuria being less than 30 milligrams per 24 hours, micro 30 to 299, macro greater than 300. and levels exceeding 30 milligrams per day predict adverse cardiovascular outcomes. Levels exceeding 300 milligrams per day are ultimately pretty diagnostic for underlying diabetic kidney disease and are associated with an accelerated decline in kidney function. And really, really importantly, once there is proteinuria on the dipstick, you have missed the boat. There is already macroalbuminuria. So I'd like to just update you on this very important and emerging concept. It's not quite so emerging, but we're still all getting our heads around it. And that's this dangerous trio of cardiovascular disease, kidney disease, and diabetes. These three conditions, as we're all aware, very frequently coexist, and their interplay significantly worsens patient outcomes and drives poor prognosis. This critical overlap is increasingly recognized as a distinct clinical entity, now referred to as the cardiovascular kidney metabolic syndrome. And there's even now a proposed staging of the CKM syndrome that progresses from health, and which is stage 0, where there's no risk factors, but one really needs to be very focused on prevention and preserving kidney and cardiovascular health. And this progresses through all different stages, from excessive dysfunction, obesity, metabolic risk, subclinical cardiovascular disease, and clinical cardiovascular disease in the CKM syndrome. Luckily, diabetes treatment has come a long way. New therapies now offer cardiovascular protection and slow kidney disease progression, especially in type 2 diabetes. These advances are improving survival and quality of life for patients. I think you'd all agree that keeping people off dialysis is life-altering. So early diabetes, as I mentioned previously, is a state of hyperfiltration. In the beginning, there is afferent arteriolar dilatation and efferent arteriolar vasoconstriction, and this really is improved with the addition of an ACE inhibitor or an ARB. However, despite RAS blockade, there still remains a large component of residual risk. RAS blockade, on average, only slows down diabetic kidney disease by about 4 to 7 mils per minute per year. So, excuse me. So, just want to review these early trials of ARB blockade in diabetic kidney disease. If we focus on the slope of eGFR decline, you'll see that even with treatment, the improvement is modest, slowing progression by around 4 mils per minute per year. This relatively small effect highlights an important point in that a substantial relative risk of CKD progression remains despite therapy. These early trials set the stage, but also made it clear that we need more effective strategies. So then along comes the SGLT2 inhibitors, the gift that keeps giving to diabetologists, nephrologists, and cardiologists alike. And I just want to run through this trilogy of SGLT inhibitor trials. All these 3 trials were stopped early due to benefit. The primary outcome was substantial eGFR decline, 40, 50, or 57%, kidney failure, or death due to kidney or cardiovascular causes. Credence, only diabetics, down to an eGFR of 30, albumin-creatinine ratio of 300 milligrams per gram. DAPA-CKD, adults with and without type 2 diabetes, eGFR down to 25 mils per minute, and a lower albumin-creatinine ratio down to 200 milligrams per gram. And then EMPA-KIDNEY, adults with and without type 2 diabetes, and 2 arms to this trial, eGFR down to 45, and a urine albumin-creatinine ratio down to 200, or an eGFR down to 20, irrespective of albuminuria. As I said, all these trials were stopped early due to clear benefit. So how do they work? Well, SGLT2 inhibitors work by decreasing sodium glucose uptake in the proximal tubule, increase glucose delivery, SGLT2 upregulation, SGLT2 inhibitors decreasing this, which actually increase sodium delivery distally. If we increase our sodium delivered distally, this then results in inhibition of RAS and efferent arteriolar dilatation, restoration of tubular glomerular feedback, altering the afferent arteriole and preventing resulting in afferent arteriolar constriction, and both of these effects decrease intraglomerular pressure and decrease GFR. So we now have strong evidence supporting the use of SGLT2 inhibitors to treat diabetic kidney disease for patients with CKD and type 2 diabetes and CKD and heart failure. There's 1A recommendation to utilize SGLT2 inhibitors down to an eGFR of 20 mL per minute, regardless of proteinuria, for those without type 2 diabetes and CKD. If you have albuminuria, you can use an SGLT2 inhibitor down to an eGFR of 20 with strong evidence, grade 1A evidence. But if your albumin creatinine ratio is less than 200, it's still recommended to use an SGLT2 inhibitor down to an eGFR of 20, but the evidence is weaker at grade 2B evidence. So I'm just going to move away from the SGLT2 inhibitors and briefly discuss the GLP-1 agonists. And we can conceptualize these drugs as anti-inflammatory in nature. GLP-1s are analogs of the incretin hormone GLP-1. They increase insulin and reduce glucagon secretion in a glucose-dependent manner. They can drop your HbA1c by about 0.6 to 1.6%, regardless of your eGFR. As we're all aware, they promote weight loss, and they are metabolized by target tissues and don't require dose adjustment in CKD. The FLOW study, which was released last year, was the first study designed to demonstrate primary kidney endpoints using semaglutide in patients with CKD and type 2 diabetes, as well as assessing cardiovascular mortality. And this trial showed that 1 milligram of semaglutide reduced the risk of kidney disease progression, as well as cardiovascular and kidney death, by 24% compared with placebo. And then briefly, I'll touch on the mineralocorticoid receptor antagonist. Mineralocorticoid, or AMr overactivation, causes kidney and cardiovascular damage through dysregulation of homeostasis, inflammation, and fibrosis. And you can see activation of your aldosterone receptor leads to endothelial dysfunction, fibrosis and arterial stiffening, macrophage infiltration and T-cell activation, and heart failure. And the effects of these can be ameliorated by finerenone. And just to note that they're particularly effective on reducing proteinuria, as their effects are on the kidney and assist with the inflammation and podocyte damage. I like this slide. It's one of my favorites, and you can see right at the top, I'm just going to show you, is the line that shows natural aging of the kidney and what happens to your GFR, and it declines about 1 to 1.2 mils per year. Down the bottom is the slide for if you have CKD and your GFR decline, and then moving up from that, the green line is when you have an SGLT2 inhibitor, RAS inhibition, as SGLT2 and RAS inhibition, what happens to the slope of the curve. And the one above that is if you add RAS, ACE, and a mineralocorticoid receptor antagonist. So you can see there really is an improvement in the progression of CKD by the addition of these new drugs. So the KDIGO have shifted towards a pillared approach, and that is pillar 1 is the diet and lifestyle modification. Pillar 2, metformin, your SGLT2 inhibitor, RAS blockade, and a statin. And then 3, your GLP-1 receptor agonist, antiplatelet therapies due to the high cardiovascular risk, and your non-steroidal MRAs. And then finally at the top, improving glycemic control with insulin, blood pressure control, and lipid management. So I think this is a lovely way to see how all these drugs work and in which mechanism they do so. The hemodynamics, we see the ACE, the ARBs, and your non-steroidal MRAs, as well as your SGLT2 inhibitor. Then your metabolism, high glucose, combated by your SGLT2 inhibitor and your GLP-1 receptor agonist. And then the inflammatory effects combated by your non-steroidal MRA, your GLP-1, and some other drugs as well, which I haven't discussed today. That's the soluble guanylate cyclase agonists. So finally, I hope a holistic approach is really necessary, and this involves healthy lifestyle interventions as well as prevention. It's really important that we stop smoking, think about salt reduction, healthy diet, lifestyle, cholesterol targeting, non-steroidals, always bad in kidney disease, and then don't forget about targeting blood pressure and your glucose. And with that, I thank you very much. And I think I've just done it in time. Thank you for your attention.
Thank you very much, Nicci. Great talk showing the dramatic progress that occurred in the care and monitoring of patients with DKD in the last 5 years, actually, just before COVID. The first credence trial was 2019, as you showed. So I'm sure there are questions.
Okay, so the questions which were left over from the previous talk, I've already answered them, and there are no new questions so far, but we'll address them as they come along. So I think we can move along and we'll collect those questions subsequently. Thank you. Wonderful talk, Nicci. Thank you.
Very nice. Thank you so much.
There's one question. There's one question, I'm sorry. So all from Rola Kutub, all SGLT2 inhibitors studied were in overweight and obese, high BMI. Is it indicated in normal BMI?
Yes, so there's overwhelming evidence that SGLT2 inhibitors work in diabetes, non-diabetics, CKD, as well as proteinuric kidney disease. Absolutely, really, they have revolutionized the treatment of diabetes, heart failure, and diabetic kidney disease, as well as non-diabetic kidney disease.
Yeah. And another question is, can we use SGLT2 inhibitors in eGFR less than 20 now?
Okay, so there's ongoing evidence to say that we can go lower. I think the general feeling is that they've got very good protection against the heart, and that if we've actually started them, we should continue them. I think, they do work in the level of the kidney, but they clearly work in other areas as well. So we continue them. I wouldn't stop them if the GFR goes below 20, but I don't think I would recommend starting them when you've got a patient who has a eGFR of 20 or below.
And role of GLP-1 agonists in non-diabetic CKD at this point?
No evidence at this point in time. So that I can, but who knows? We didn't think that about SGLT2. So I don't, they have got an anti-inflammatory effect. I guess, time will tell, but at the moment, there's no evidence.
Okay, so, and again, should we add SGLT2 and non-steroidal MRAs to RAS inhibitors in CKD plus DM sequentially, or they should be started all simultaneously?
Okay, so the KDIGO doesn't really recommend that currently. I think that we will change that with time. I think we have to think about the individual patient. If you have heavy proteinuria and you're not on target and you've got not controlling your proteinuria, yes, I would add your SGLT2 with a very low threshold to start finerenone if required. At the moment, the recommendation isn't to start together, but to start them sequentially. But that might change.
Sure. Now, the SGLT2 inhibitors in dialysis population, any role for cardiovascular benefits?
I would say yes, there is a role. I don't think I would start them with an eGFR less than 20, but I would continue them because of their protective effect on the heart. That is my feeling. I don't think we have any evidence in dialysis patients. And SGLT2 inhibitors in type 1 diabetics. Okay, the studies were done in type 2 diabetics. There is a real risk of DKA, but just remember that they have very good heart protective effects. So I would suggest that you can use them in type 1 diabetics. You just have to be careful about the risk of DKA. Okay,
and can we use these MRAs, non-steroidals, in IgA nephropathy?
No evidence. That I'm aware of, but maybe Prof. Ronco can add, but there's no evidence that I'm aware of.
Prof. Ronco, any comments on this wonderful talk and these questions? Thank you.
Thank you so much, Professor Nicci and Professor Mujtaba. Very nice discussion. Give us a fantastic presentation. about the ANCA-associated vasculitis, the new guidelines. So we'll do this, and after that, we'll do Professor Rasha Samir Luba's lecture.
This heterogeneity of this clinical entity. Now, vasculitis, as you know, is the inflammation of the blood vessels, which can cause narrowing, leading to microaneurysms in certain cases, and also can lead to organ ischemia. The classification is based on the size of the vessels, and for our interest, the most important area that we have to be worried about or sort of concerned about is the presence of renal limited vasculitis, the common ANCA-associated vasculitis. So these are the groups I would be talking about mostly in this webinar. Now, the signs of symptoms are actually predominantly pulmonary, where you may even have severe alveolar hemorrhage. Then you have the laryngotracheal in GPA, and the renal involvement is actually hematuria, proteinuria, and renal failure. But most patients actually have constitutional severe symptoms of fever, weight loss, and malaise. Now, ANCA-associated vasculitis is a form of group of autoimmune conditions, which include actually, as we know, GPA, EGPA, and MPA. Other ANCA-associated vasculitis include drug-induced vasculitis and renal-limited vasculitis. The link between these antibodies, antineutrophilic cytoplasmic antibodies, and the clinical entities was established way years back in 1988. The further examination of these patients with crescentic gene actually showed that there were two types of antibodies in the neutrophils. One had a perinuclear staining, which were called P-ANCA, and the other one had a cytoplasmic staining, which was C-ANCA. Now, these autoantibodies are against either the azurophilinic granules of neutrophils or the lysosomal granules of monocytes. If you test the serum of the patient with ethanol-fixed neutrophils, you get two different distinct patterns in immunofluorescence. One is the perinuclear and the other is cytoplasmic. Now, if you do a ELISA testing of identifying the antigen bound in plates, you actually get the antigen binding levels of both MPO and PR3. These are not actually standardized, but they are important, and as there are poor correlation between IFA and EIAs, both tests need to be done, both the immunofluorescence and enzyme immune assays. Now, the association with ANCA actually shows that the serology is positive in 90% of GPA and MPA cases, but only 30% in about EGPA cases. C-ANCA is 90% has a PR3 reactivity, whereas P-ANCA has a 90% MPO reactivity. Both anti-PR3 antibodies are 90% sensitive for GPA, whereas anti-MPOs are sensitive for MPA. So, although specific for GPA, C-ANCAs, actually positivity C-ANCA, that is, it's been shown to be positive in 15 to 20% of patients with SLE, that is because of the presence of anti-nuclear antibodies. ANCA-negative vasculitides are also seen in 10 to 20% of patients. And then there is a group of double positive vasculitis, which is, I think, beyond the scope of this webinar. Now, we need newer biomarkers, and there are newer biomarkers coming out in literature. They essentially include circulating immune cells, complement factors in the blood, and the genes transcripts in the granulocytes. Urinary biomarkers are actually soluble complement factors, and there are other epidermal growth factors and CD3 and T-cell regulatory markers. The biomarkers which sort of tell you about organ damage actually are endotrophin, and in urine, even besides endotrophin, you have mitochondrial RNAs. The study which I have highlighted has been just published in Nature, which actually identifies a single cell analysis of a type 2 interferon-related subset of neutrophils, which have a higher level of activation of MPO and Fc gamma receptors. These neutrophils actually have ANCA-induced nets And these nets actually leads to inflammation. So this neutrophil subset of T2-ISG can actually work as a biomarker of ANCA-mediated vasculitis. Now we look into a case. This is a 38-year-old lady who presented to us with progressive breathlessness, weakness, burning feet, and reduced urine. She had no cough, hemoptysis, or fever. There are no comorbidities in the past. Her routine investigation showed anemia, severe renal failure, hypocalcemia, hyperphosphatemia, and a proteinuria of 1.3 grams. Normal sized kidneys, her p-ANCA and anti-MPO were positive, whereas the ANA, dsDNA, anti-GMPM came negative. Her complements were normal. Because she had breathlessness, a CT scan of the chest was asked for, which showed bilateral, though more on one side, confluent opacities. And in our part of the world, the first thing we think of this is an infection. So a bronchoalveolar lavage was asked for, which was completely non-contributory for infection. There was no pulmonary hemorrhage. Hence, a kidney biopsy was done. When we have a patient with suspected ANCA-associated vasculitis, the biopsy actually we look for and we'll find out about the presence of fibrinoid necrosis in the glomeruli or crescents. Sometimes you may have capillary angiitis also and capillaritis in the interstitium. When you have this kind of a biopsy, we look at for the extent through the burden classification, where the histopathology is further divided as focal, crescentic, sclerotic, and mixed. This has an importance because this has prognostic information. Now, unfortunately, our biopsy, if you look into it, on a single layer looks like a crescentic gene, but it was not. It was a collapsing glomerulopathy. Now, collapsing glomerulopathy and AAV are slightly difficult to reconcile. So we went back and looked into the lung biopsy, which showed the presence of eccentric vasculitis with a lot of neutrophilic infiltration. Urgent or an early peripheral nerve biopsy was also asked for perineal, and that showed the presence of a vasculitis in the vasa nervosum. So this is a patient of AAV with collapsing GN. This is not, CG is actually not a typical feature. And both occurring in context with AAV is actually because of the autoimmune form of collapsing CG. Exact mechanisms are not clear, but it is believed that presence of CG in the kidney biopsy actually indicates a very severe vasculitic process of severe ischemia. Patients with AAV who have CG actually have a worse prognosis. However, the treatment offered is that of AAV. There are a report from India where there was both collapsing GN and AAV, and then there was an abstract in Kidney Week in 2020 regarding the same. This patient underwent an ID consult to rule out para-infectious vasculitis, which can happen with tuberculosis and infective endocarditis. When that was ruled out, she was pulsed with methylprednisolone and was put on fortnightly cyclophosphamide intravenous. She was also plexed because of a presence of severe renal failure. Then she showed gradual improvement of her renal function. Now she is off dialysis. A current follow-up creatinine is 3.5 milligram. She is on tapering dose of steroids. We have given her 2 doses of IV cyclophosphamide fortnightly. Now she is going to be cyclophosphamide every 3 weeks. The other prophylaxis of cotrimoxazole, pantoprazole, calcium, phosphate binder, anemia treatment continues. A patient with AAV actually needs to be diagnosed and separated as EGPA or the other two vasculitis. And we have to actually get an induction of remission, and which we do in our part of the world with either glucocorticoid or Ritux, either glucocorticoid with Ritux or cyclophosphamide. Sometimes we may use MMF, methotrexate, avacopan, and Plex depending on the requirement. After inducing remission, the definition of which is not very clear, we maintain these patients for about 24 to 48 months depending on the personal disease activity. Here, both Ritux and ASA or MMF or methotrexate is used. The glucocorticoids are usually used as a pulse initially, and then we taper. In our part of the world, we taper according to the Pexivas schedule. Cyclophosphamide we use it as an intravenous 15 milligram per kg. We do that initially fortnightly, then every 3 weeks to up to 6 months. Ritux, we either use 1 gram for 2 weeks or 375 milligram per meter square weekly for 4 doses. A combination of Ritux and cyclophosphamide has been offered. We don't have any experience, but this has been offered in various trials. Avacopan is not available, but can be used orally as 30 milligram twice a day. For maintenance, it's either rituximab or azathioprine. But in carefully selected patients, we may use MMF for both induction and maintenance. Methotrexate, where there is not much of renal involvement, for both induction and maintenance. Mepolizumab can be used for EGPA and IVIG for refractory disease. Now, management and the use of drugs requires personalized decision. Like for severe kidney disease, Plex and Avacopan should be also offered. In elderly frail patients, it is Ritux, preferably, and steroid-sparing strategies with Avacopan if available. Ritux over cyclophosphamide should be considered in premenopausal women with fertility issues. Similarly, a combination of Ritux and cyclophosphamide can be offered to patients with severe kidney disease, patients with slow response, refractory disease, in whom we worry about glucocorticoid toxicity and/or cyclophosphamide toxicity. Avacopan can be added to patients with low GFR, who we are concerned about glucocorticoid toxicity, and in patients with refractory disease. We have learned a lot from various trials that like rituximab is non-inferior to per-oral cyclophosphamide in RAVE. Ritux and cyclo can be combined in severe disease with less side effects in rituximab. In maintenance, rituximab is preferred over azathioprine in Mainrestan and Ritazarim. Avacopan can be used for sustained remission as shown in Advocate trial. And low-dose steroids are as effective in both Lovas and Pexivas. In Pexivas, the dose of glucocorticoid has been conclusively shown that a reduction in dose and a rapid taper actually makes no difference in the primary endpoints of death and ESKD. Similarly, Avacopan can replace or sort of allow us to have a rapid steroid taper in these patients, and it has been shown at 1 year, use of Avacopan actually maintains a sustained remission in a higher percentage of patients, as shown in the trial. In Pexivas, the role of Plex has been brought into question, especially when you are looking for a primary endpoint and ESKD or death. It has not shown to be of any importance, but a subset analysis has shown Plex actually has an impact, significant impact in a subgroup of patients who had severe renal failure in the onset as far as their renal outcome is considered. Nowadays, there are newer therapies which are coming in the form of targeted therapy. Most of them are actually around the use of B cells and using sort of inhibiting BAF. Then there is a group which looks into interleukin levels, and then there is a group which is looking at complement inhibition. There are experimental animals which have shown inhibition of myeloperoxidase per se can actually reduce endothelial inflammation in ANCA-associated vasculitis. This kind of specific therapy will be hopefully available in the future. So now what is our future? We should have newer biomarkers to reduce dependence on kidney biopsies and other affected organ biopsy. Then in this patient, we have 3 biopsies to come to the diagnosis. Duration of therapy should be well defined, and everything should be targeted to reducing relapse, which is still unacceptably high. The use of B cell and complement inhibitory therapies have come to stay and will become the new norm in the future. Therapy should be based on the type of AAV rather than the severity of AAV, which we continue still. And hopefully, in the bucket list of all nephrologists, there should be new agents which will improve the renal recovery. Thank you very much for your kind attention.
Thank you very much for a great talk indeed on vasculitis and the new advances in treatment. So there are questions for you from the floor. Could you please summarize the question, Amir?
I'm not being able to see the questions. I think there are no questions
But
on my screen. Dr. Ahmed, if you have any questions.
There's one question here. Somebody talked about typical ANCA vasculitis and then with positive titers of anti-GBM as well. So the dual burden and how does it affect the management?
Yes. Okay. Professor Ronco, anything on the dual vasculitis?
yeah, I think this is an important question. The association with anti-GBM disease is associated with more severe outcome and is an indication to plasma exchanges and reinforced therapy with monitoring of anti-GBM associated with ANCA. So I think we are close to anti-GBM nephritis here, and the treatment should aim at eradicate or decrease the production of anti-GBM, especially if there is a fluorescence linear fluorescence in the biopsy.
Professor Ronco, what do you say about ANCA negative vasculitis, which is quite common in our part of the world?
Yeah, but I
Either
think
we miss it or we don't have the technical know-how, or what is your
Well,
concept of this?
Well, we do not know. I think I can draw a parallel with anti-DNA negative lupus nephropathy. ANCA is the most frequent biomarker associated with disease, but there are truly seronegative forms. And I think the patient should receive exactly the same treatment as those with ANCA-positive vasculitis. The key question is the treatment is steroid-sparing therapy, as you mentioned. It's really important. Now we have a portfolio of drugs, and especially rituximab, that allow to reduce very rapidly, very quickly, the dose of steroids. And this is very important because of the risk of infection. But to the best of my knowledge, there is no difference between ANCA negative, which represents 10 to 20% of all cases overall, maybe more in India, but they should be treated in the same way.
Professor Ronco, there is one more patient which is even very important for us also. Could we depend on indirect immunofluorescence or just directly go to ELISA?
Well, I think both are important. The immunofluorescence is not quantitative. So if you want to follow the titer of MPO or PR3, you have to perform ELISA. So I think both tests are important, and you could start with the immunofluorescence because you can have the data, you can have the results in one day. I mean, if you have a quick pathologist, if I could say so, it's very simple. Where ELISA, you need to wait for other samples for economical reasons. So I think you can start with immunofluorescence and then measure the antibodies by ELISA. It really depends on what is available in your center. What is available in your center? Can you start with immunofluorescence?
Both. We have both, but immunofluorescence comes within 24 hours.
So
The other one takes about 48 to 72 hours. But our problem is that there are various forms of ELISA. And as you said, the titers may not be, very reliable. So we start with some titers and then we don't know where are we going. So I think we do both and just look into the titers and take it forward. So
okay. Agree with the strategy.
And there was a question also about the assay. Do you depend on immune fluorescence or go directly to ELISA?
Is this a question for me? Oh,
Yeah,
Yes,
you
sir.
can answer it, or Urmila can do.
please.
Professor Ronco just answered that. He said we should do both, I think, depending on. He said the I
On the availability.
comes early and the ELISA.
If both are available, the results of the immunofluorescence data are quicker. But if you have only ELISA, you perform ELISA.
Very nice, very nice. And what do you do? There is a question also. Sometimes the titer is very low. How do you titer the management depending on the ANCA level?
Well, please answer the question. I can answer, but
Urmila, go ahead, please.
So we don't, as we said, in our part of the world, it's a combination of clinical findings, histopathology, and the titers. If the titers are very low, we would still treat some. We cannot play with ANCA-vasculitis, and we will treat is the way we want to treat. And this, sir, you also agree, we also agree. We treat the severity of the disease. We are not treating EGPA separately from MPA, or we are not treating MPA from in our part of the world, MPA is more common. It happens in youngsters, and they present with very severe form of renal failure. So we just go ahead, do the biopsy, pulse them, and within 2-3 days, cyclophosphamide is in. Then comes the thought process: should we change them to Ritux or not? I mean, it all depends on our some epidemiology of our patients. I think the rest of the world or others, they have more GPA compared to MPA fast. I think
We don't
Dr.
only
Quadri
focus
may
on
be able to
numbers,
guide
right?
something.
Yeah, I mean,
Yeah,
I think
Dr. Quadri,
that's a similar experience, and you just go with the clinical features and the renal biopsy, and if you see the necrotizing granulitis, we don't care about the ANCA titer. Sometimes they'll come after 2 weeks.
Yeah, I completely agree. Clinical presentation is the most important, and not only for the diagnosis, because if you have necrotizing crescentic nephritis without endocapillary proliferation, without immunoglobulin, but immunofluorescence, the first diagnosis by far is ANCA-related vasculitis. That's for the diagnosis.
Yes,
and then for the monitoring, I think renal functions, monitoring of renal function, of hematuria. Hematuria is very important because it's probably the most reliable sign of glomerular activity. And whatever the level of anti-MPO or anti-PR3, it's a little bit different. If you are uncertain about the outcome, perform a second kidney biopsy, and then you will see whether the disease is active or whether there is essentially fibrosis, which of course is fundamentally different with regard to treatment. So, the kidney biopsy is still, in ANCA vasculitis, a very important procedure.
true, sir.
Very
you agree?
nice.
Yeah, you agree, I think.
Yeah.
Yes, sir. Yes, sir.
Consensus on that.
Because
I think
recently there is an article in Kidney International, I think this week itself. They believe even if ANCA is negative, we still treat them.
Yes,
in the youngsters and all. Yeah.
That's what I said. I mean, ANCA is different from anti-PLA2R. If you want to draw a parallel, in most cases of membranous nephropathy, immunological remission, that is the disappearance of PLA2R, precedes the clinical remission. And if anti-PLA2R increase, you will have a relapse. The relation between immunological activity, that is ANCA, in the serum, and clinical activity is not so tight in ANCA vasculitis. There is a loose relation between the presence of ANCA and the activity in most cases.
very nice.
You would prefer negative ANCA, of course. But the clinical presentation and symptoms are still very, very important. And we should teach our students that looking at the urine is important.
Very nice. Thank you so much, Professor Piere Ronco, Professor Urmila Unandh, Professor Mujtaba Quadri, Professor Nicci, Wearne, and also thank you, Professor Rasha. But because of the sake of the time, Professor Rasha agreed to postpone her lupus presentation until the next webinar. So we will have a dedicated lupus nephritis webinar. We'll be also inviting a nephropathologist to give us very good educational background about lupus nephritis classification and the stages and diagnosis. Then Dr. Rasha will give us the up-to-date management. Just for the sake of the time, I really
Can I add something? Can I
yes,
interrupt?
sir.
Yeah,
Yes.
because there was a question on what the name of the super rituximab, and this is a very important question because obinutuzumab, O-B-I-N-U, T-U-Z-U-M-A-B, will revolutionize the treatment of lupus nephritis. So it's important to know the name, obinutuzumab. Sorry for interrupting you. But there was a question in the chat.
That's very good. This clarification is very important, I think. Thank you so much. Professor Nicci, Professor Mujtaba, Professor Urmila, do you want to add anything before we conclude our tonight's or today's webinar?
No, just nice to be here and see everybody. And thank you very much, Piere, for being the moderator. It was excellent. The discussion was really great.
Thank you, Nicci. I remember the good time where I was chair of the scientific committee of the WCN in Cape Town.
Yeah.
And we met several times, and this was a memorable WCN with Desmond Tutu and the the opening ceremony, the drums, etc. I will remember that all my life.
Thank you so much. And also because we missed Professor Georgina Bicoli today, so she will be mastering and handling the discussion with Professor Rasha regarding lupus nephritis in our upcoming webinar.
Okay.
Thank you so much, everyone. And we'll see you probably in a couple months.
Okay. Thank you. Thank you for
Bye,
the
everyone.
Thank you for the
Bye.
invitation. Bye-bye, Nicci. Bye-bye.
Bye.
Bye-bye, Nicci.